So a very warm welcome to this Global Coalition for Circulatory Health webinar on circulatory risk factors for COVID-19. This is the first in a series of 3 webinars being hosted by the Global Coalition for Circulatory Health. My name is David Wood. I'm a former president of the World Heart Federation and a member of the leadership group of the Global Coalition for Circulatory Health. As of today, there are more than 8 million cases of COVID-19 worldwide, according to Johns Hopkins University. And the highest death toll is in the United States of America, followed by Brazil, and sadly in the United Kingdom as well. It really is a truly global pandemic challenge. The Global Coalition for Circulatory Health was formed in Singapore in 2017 at the World Heart Federation Global Summit. And at this summit, we invited all of the international organizations with a stake in circulatory health, obesity, hypertension, diabetes, nephrology, tobacco, and many more besides, to come together to form a coalition which would be in a more powerful position to advocate to politicians and policymakers for better prevention and control of circulatory diseases. The epidemic of COVID-19 highlights the interdependence of all of these specialties, because we see from the scientific reports that patients with comorbidities, with obesity, with hypertension, with diabetes are all at much greater risk of dying from COVID-19 than people without those comorbidities. And therefore, there is even more reason for the international societies with an interest in all of these risk factors to be working together as we are today on this webinar. I'm joined by a distinguished panel of leaders in the Global Coalition for Circulatory Health, and their knowledge and expertise will help us understand better what is happening with this pandemic and the impact that it is having on people with circulatory disease and how we may be able to best help. And the first of our speakers is Professor Vivek Jha. He is president of the International Society of Nephrology, executive director of the George Institute for Global Health India. And Vivek, I give you the floor to address improving the skills of frontline health workers through digital health. Thank you.
Thank you, David. And if I might add my own welcome to all the attendees on behalf of the Global Alliance for Circulatory Health, and Global Coalition for Circulatory Health rather, and the International Society of Nephrology for joining us in this webinar to discuss different topics, and we'll go through each of them one by one. So let me just frame this topic by talking a little bit about what are the treatment gaps for circulatory disease in low and middle income countries. So if I may, let me read these bullet points. I think we all are persuaded there is a large undiagnosed and untreated population. There is an inadequate healthcare workforce, and it's very clear that dependence on the Western physician-centric model of healthcare delivery is not necessarily going to work, especially in low middle-income countries. Our healthcare systems have given a disproportionate focus on curative treatment to the detriment of effective organized community-level early detection and treatment programs. And in many places, there is a severe lack of guideline-based care. I think there are just 2 facts which is worth remembering from our point of view. If you look at the global north, there are about 80 million people who have some sort of cardiovascular and diabetes conditions, and the amount of money that is spent on them is approximately US $100 billion. Whereas in the global south, that corresponding number is more than uh, 3.5 times. And the amount of money that is spent on their care is less than 1/5. So you can imagine the stark difference there. Similarly, the number of healthcare resources here indicated by the number of doctors per 10,000 population in different WHO regions. You can see North America, Western Europe between 27 and 30, East Asia and Latin America 14, South Asia 6, and Sub-Saharan Africa, parts of Southeast Asia 1 to 2 per 10,000 population. And there is an equal shortage of other cadres of healthcare workers in these regions as well. So then how do we develop sustainable solutions? Where do we need to start? I think all of us agree now that the first thing we need to do is to re-engineer the healthcare workforce from the expensive, less readily available physicians to larger and less expensive frontline healthcare workforce, and to ensure that this workforce is able to deliver care with less variation in quality. How do we do that? And this is where technology comes to our help. And the two technologies that we would like to pick up on are electronic decision support systems and point of care diagnostics. There is also a need for us to think about pharmaceutical reforms, but we will not talk about that there. And I'll give you an example of such a model in which frontline healthcare workers are using technology to provide healthcare in rural Indian communities through primary healthcare system. And this program is called Smart Health India. This is a village-based healthcare ecosystem which utilizes healthcare technologies. And this healthcare is actually delivered by frontline community healthcare workers. They are under regional medical supervision. They use smartphones and are able to provide personalized care through specific guidance. They are able to use simple wireless point of care diagnostics in the field. They have access on the smartphone to evidence-based algorithms, which are both clinical and operational, and these algorithms provide a continuous quality control mechanism. This is a kind of framework of how this system works. So on top left, you see that the healthcare worker provides at-home cardiovascular disease risk factor screening, enters data into the so-called Smart Health platform on a mobile phone or a tablet device, and it spits out a care plan through a decision support system, which is provided by the healthcare worker to a patient, and high-risk patients are referred to primary healthcare center. Consented data is uploaded to a secure health record. The doctor in the primary healthcare center is able to review these high-risk patients with their own data, which has been uploaded by the healthcare worker. And then the doctor receives another level of decision support for medication prescription with care plan to be sent to the healthcare worker. And this care plan is then transmitted both to patients and to healthcare workers, and then this loop continues. This program with the healthcare worker shown here in the middle actually has a number of components, which includes training of healthcare workers through a virtual training platforms. It's very important for us to recognize the value of these healthcare workers and make sure that they're appropriately remunerated. For this program to be successful, it requires support from the healthcare system, which is typically provided by the government. And we need to make sure that these people also have access to high quality essential medications. Now, in terms of delivery, there are a number of mechanisms. I already discussed the decision support system, but this Smart Health, which is a digital platform, also provides risk communication, has a number of multimedia resources, recall and reminder system, and interactive voice response for use both by the patients and by the healthcare workers. I'll show you just this one slide to show that this actually works, and this was a paper which we published more than 8 years ago now, which shows that actually the community healthcare worker was able to identify using a standard algorithm high cardiovascular disease individuals at high cardiovascular disease risk, in fact 12% much more efficiently than a primary healthcare physician who was not trained in these specific algorithms. So this proposal really works, and subsequently us and a number of other organizations have shown this to be the case. So in the end, what do we need to make sure that this primary healthcare system, which is centered around frontline healthcare workers, and in this picture you can see the frontline healthcare workers interacting with patients during the time of the COVID pandemic. In India, they have been redeployed now to carry out screening and contact tracing activities in the community, and they are doing this job admirably. Had it not been for the frontline healthcare workers, our healthcare system would have suffered badly in this situation. So what we need to help them are appropriate policies to facilitate their work, protocols of care. We need a standardized mHealth training package. It's really important that we protect our healthcare workers, especially in the time of this COVID pandemic. We need to respect the importance of confidentiality and make sure that mHealth interventions are integrated with existing electronic health information systems and programs. A number of these countries also have routine surveillance mechanisms, and recording routine patient surveillance data can immeasurably help advance this program. But to make all of this happen, we require political will. So I'm going to stop here, and I'll pass on to David once again, so that we can move on with the various presentations, and we'll come back to the question and answer session at the end. Thank you very much.
Thank you very much, Vivek, on behalf of the International Society of Nephrology. And it's a pleasure now for me to introduce Professor Andrew Bolton, who is president of the International Diabetes Federation and professor of medicine at the University of Manchester in the UK. And Andrew is going to address diabetes-related complications of the lower limb in the context of COVID-19. Andrew.
I think you're all familiar that we have a major problem globally with diabetes, with 500 million cases across the world. Just a couple of examples. For example, in Pakistan recently, 1 in 4 adults has been shown to have diabetes, and the prevalence is equally high in many of the Middle Eastern countries. Now, with respect to diabetes and COVID-19, if we look at Wuhan, the good news is that there were very few people admitted under the age of 35 with diabetes, but around 10% of all COVID-19 hospital admissions did have diabetes. The median age was older, and adverse outcomes were affected to age, cardiovascular complications, and poorer glycemic control. So if you compare the risk of mortality in those with diabetes admitted with COVID-19 with those at risk of diabetic lower limb problems, you'll see that there are great similarities, in fact, identical. So the at-risk population is older, male with poorer control, hypertension, and cardiovascular disease. And those are the very people at risk of problems. So there are threats with the COVID-19 in the management of diabetic lower limb complications, including the cancellation of all routine outpatient clinics. Access to medications can be limited in some countries, suspension of all routine investigations, including x-rays in many Western countries, and suspension of all non-emergency surgery and transplant surgery. If you look at the threats to those with neuropathy and peripheral arterial disease, they're of course similar. The suspension of all routine lab tests. Junior doctors rely on the CRP rather than looking at the patient. Suspension of all routine investigations, not only x-rays, but other imaging and routine non-invasive vascular tests, and suspension of all non-emergency surgery, including bypass, not only for peripheral arterial disease, but for coronary artery disease. So we just published in the last week a paper in Diabetes Care called Saving the Diabetic Foot During the COVID-19 Pandemic, A Tale of Two Cities. And not as in Dickens, London and Paris, but as Manchester, UK, and Los Angeles. We looked at the caseload and compared 6 weeks before and after lockdown started. This is the most complicated slide, and you can see here at the top is Manchester, at the second half is Los Angeles, and in each pre-lockdown and post-lockdown figures. Clinic visits reduced in both centres. the bringing in of telecare, including video, but in the UK more telephone consultations, increased. Domiciliary podiatry visits is new in the UK and has started, and the number of patients we've hospitalized from the clinic significantly reduced in both centres, which is very important because of the risk of these patients should they, of course, get COVID-19. One or two case vignettes. The first one here, this is from Manchester, a 73-year-old male, type 2 diabetes, known neuropathy and complications, presented 3 weeks prior to lockdown with an extensive ulcer of the interphalangeal joint on the hallux, you can see here, probe to bone and distension of the toe. Just before lockdown, we could get an X-ray, and you can see here extensive osteomyelitis involving both the phalanges and septic arthritis there. Now, normally we would have treated with antibiotics and admitted to hospital, probably for local surgical debridement or even resection of the most of the toe. But on this case, we decided to start with broad spectrum antibiotics, and we were about to admit him when this wasn't possible, and we therefore decided to continue with clindamycin and ciprofloxacin, and remarkably, this is healed beautifully, and 4 weeks after lockdown, I just saw him last week, continues to be healed. A second vignette here, again, male, you'll see they're all males, these cases. This is a typical population. Previous third ray amputation, presented in the first week of lockdown to our hot clinic off-site, and I've moved all my patients away from the hospital to a community clinic. Grossly swollen right toe, cellulitis, and a plantar ulcer. Monophasic waveforms in the dorsalis pedis, again probe to bone, and this positive, what we call sausage-shaped distension, which has been clinically described as a sign of osteomyelitis, and you can see this probe straight up here and a purulent discharge. Again, normally this would have been probably a ray amputation. He's already lost one toe, as you can see, but we again continued with the same antibiotics, and just 3 weeks ago we had made this progress. So another case we've managed to avoid admission. A case from the United States, from Los Angeles, a patient who's had previous bilateral popliteal perineal bypasses. 2 weeks prior to lockdown, had an open transmetatarsal amputation on the left. Had vacuum-assisted closure therapy, but extensive slough developed, and he was reluctant to attend the hospital clinic. So my colleagues in Los Angeles were able to direct larval therapy to a home visiting nurse who had never done this before, and apologize for this, but this is after the second application of larvae. You can see these large larvae and a beautifully granulating wound which healed up. And the last one from Los Angeles, again, a patient who developed wet gangrene, a local infection, and was terrified to come to hospital because he was living with his daughter who was pregnant, and he was really frightened of catching COVID-19. So he was treated with oral antibiotics, and later was able to undergo a partial amputation in a clinic off-site the hospital. And you see here pre-op, and here 3 weeks post-op, and this has gone on to heal. Lastly, not all the cases are good. Here's an 80-year-old, a typical problem. He sought advice because he had localized gangrene and known peripheral arterial disease, and his primary care doctor advised him to stay away from the hospital and prescribed oral antibiotics. After 2 weeks increasing rest pain, he was forced to come into hospital, had extensive tenderness, purulent discharge, gangrene, and had to go on an emergent, required a below-knee amputation, and had a myocardial infarction soon after that, and remains very ill. So, a tale of two cities. What we've learned is the art of clinical observation remains essential. Reduction of hospital admissions is possible. Opportunities for the development and expansion of telemedicine are emphasized. And I will remind you of the words of Lindsay, who was a professor of medicine in Belfast 100 years ago, who told his students, for one mistake made for not knowing, 10 mistakes are made for not looking. Always examine the feet. And this can be done even by telemedicine and video conferencing. Lastly, I show this picture, and this is actually me 3 years ago, when I was fortunate to share the stage with Sri Narendra Modi, Prime Minister of India, at a meeting in Bangalore. And he got up and said, the biggest threat to the survival of people in India is no longer infectious diseases, but chronic diseases, non-communicable diseases such as diabetes and heart disease. Sadly, I fear that this pandemic is going to put a lot of stress on the system, especially for all of us in non-communicable diseases, and we're going to have to fight to maintain the importance of these diseases with this huge epidemic, and also for research income, which is already suffering. So I'll leave you with this quote from the book of Ecclesiasticus in the Bible: before you speak, learn. Before you fall ill, take care of your health. And this is the most important message to people with diabetes, to avoid the serious consequences of COVID. Look after yourself, especially blood glucose control. Thank you very much.
Thank you very much, Andrew, on behalf of the International Diabetes Federation. And now it's a pleasure to introduce Professor Claudio Borghi. He's a member of the Council of the International Society of Hypertension and a former president of the Italian Society of Hypertension. And he is going to address the problem of hypertension at the time of COVID-19. What is the role? Claudio.
Thank you very much, David. And oh, I don't see my screen. Let me check it. Okay. Thank you very much, David. And first of all, I would like to thank the Global Coalition for Circulatory Health and all the attendees on behalf of the Council of the International Society of Hypertension. We are all very proud to be invited to such important webinar. Basically, we know very well what hypertension, what the problem of coronavirus is. You have the problem has been already introduced. Of course, the main problems were in the respiratory system, but what is important in terms of natural history of the COVID-19 disease was the rate of cardiovascular disease. And among the cardiovascular disease, I think a primary role would be played by hypertension. If you look at the different possibilities of interaction with hypertension, between hypertension and the natural history of COVID-19 disease, at the very beginning of the infection, someone suggested that hypertension could increase the risk of infection. This has been denied later on by the evidence coming from the epidemiology, but certainly hypertension can contribute to the progression of the most severe forms of the disease, can be involved in the onset and progression of target organ damage, particularly at the heart, at the kidney level, and probably hypertension can play some role even in terms of long-term outcome of the patient survive the COVID-19 syndrome. Certainly, the hypertension had a strong impact on the clinical outcome of these patients. This is a nice paper published on Circulation at the end of April, clearly suggesting that the rate of mortality was significantly increased in the hypertensive population, even after adjustment for the most important and confounding risk factors. Actually, which one could be the mechanism? It's pretty much difficult to say, but I think probably the most reliable interaction between hypertension and COVID-19 syndrome was based on some mismatch in the activation of the renin-angiotensin system with a downregulation of the ACE2 system, who has some kind of protective effect from the cardiovascular point of view, and some overactivation of the angiotensin II. Such a mismatch between angiotensin II and the protective role of ACE2 is probably involved in many of the cardiovascular complications observed in this disease, including, of course, the role of hypertension. And some evidence have supported the presence of angiotensin II in the natural history of cardiovascular disease in these patients. This is one paper published from China, a very interesting one, showing a significant increase in the angiotensin II level in this population of patients, and the close correlation between angiotensin level, the viral infection, and the rate of respiratory involvement. Actually, I think one of the main problems that should be put on the table in terms of trying to understand what hypertension was during the COVID-19 disease was which have been the evidence of treatment, how to manage hypertension in this population of patients. Of course, hypertension hypertension was not the primary problem, but it was anyway involved in the natural history of the disease. Actually, I think the most important evidence that comes out from the evidence that has been published so far, even from our experience in my own institution, is that the antihypertensive treatment in patients already treated for hypertension should be kept ongoing, even during the infection, during the disease, particularly in the patient with mild form of the disease. Since, at least in my country, many patients at the very beginning decided to stop the treatment, in particular with drugs inhibiting the renin-angiotensin system, because of the some kind of suggestion that this kind of drug could increase the risk of infection. But of course, it was exactly not true, and the many scientific societies, including, of course, the International Society of Hypertension, have published some almost the same statement, suggesting that the first point of treatment with hypertension was to try to keep on going with the antihypertensive drug that were already taken by the patient before the infection. Of course, the treatment of hypertension should be tried to be modified during the infection of COVID-19 syndrome, but without no major changes when compared to the guidelines. The recommendation, the main recommendation were exactly the same. Of course, there are no guidelines specifics for this condition, but there was no reason to change the drugs and the treatment strategy that should be adapted to the changes in blood pressure during the acute during the acute phase of the disease. Of course, any strategy for the treatment of hypertension does not apply to the patient admitted to the intensive care unit, because in this case, the problem was more of hypertension than hypertension. They have been treated according to an intensive approach. But I think the most important problem was that hypertension should be continuous to be treated by considering the same variables that we are going to consider for the treatment of hypertension outside the COVID-19 syndrome, which is the age, which is the clinical history of the patient, the clinical and the hemodynamic condition of the patient, and the presence of the target organ damage. One important problem that comes out during the pandemic of COVID-19 was if there were some classes of drugs that should be more effective than any other for the management of hypertension. And I would say that from this point of view, maybe, even whether we don't have any prospective trials, but the evidence that comes out from retrospective analysis of data pretty much suggested the importance of drug inhibiting the renin-angiotensin system. From the very beginning, this drug has been avoided from the treatment of these patients, and even from the antihypertensive treatment at risk of infection, because it was there was some suggestion that blocking the renin-angiotensin system would raise the availability of ACE2, and since the ACE2 is strictly related to the binding of the virus, could increase the rate of infection. Actually, it was not true, and I think there were some small trials. Probably the most reliable one is this one that I'm sure you know, published on the New England Journal by Italian friends, and suggesting that the risk of a new COVID infection in patients treated with antihypertensive drug is exactly the same in patients treated with drug inhibiting the renin-angiotensin system as in those treated with any other class of antihypertensive drug. What is important is the possibility that not only the blockers of the renin-angiotensin system could be neutral in terms of infection, but they could also affect in some way the prognosis of these kind of patients. And in particular, I think the same paper I've shown you just before is probably the most interesting, which is showing, of course, on a retrospective way, that the treatment with the drug inhibiting the renin-angiotensin system is able to reduce the rate of mortality in patients affected by COVID-19. And this is true even after the propensity score analysis comparing to very similar population of patients. And this is true when you compare these kind of drugs with any other strategy used for the management of the disease. But another sub-analysis of the same paper directly compared the antihypertensive treatment by comparing directly patients treated with drug inhibiting the renin-angiotensin system with other treated with all the different antihypertensive drugs that used in this situation, and again, you would see some improvement in the mortality rate in this population of patients. And the same was true in terms of hospitalization. This is another very nice paper which is trying to investigate the rate of hospital admission and the progression of the disease in patients treated with different classes of antihypertensive drug. And again, you would see that the patient treated with drug inhibiting the renin-angiotensin system were less hospitalized when compared to patients treated with other antihypertensive strategies. So even whether we don't have any specific evidence of efficacy in terms of randomized clinical trial, in terms of prospective clinical trial, what we have from the large number of patients which have been observed during these periods clearly suggests on one side some involvement of the renin-angiotensin system, and on the other side the possibility that the modulation of the renin-angiotensin system can play some preventive role in the hypertensive patient affected by the COVID-19 disease. Finally, we have some preliminary evidence that probably the same strategy could be effective in the prevention of the long-term complication of patients with COVID-19 syndrome. And this can be very important since probably some of the things that happen during the acute phase can be observed even in the long term in the follow-up observation of these patients. So basically, I think if we look at what we have in terms of hypertension and COVID-19, we can say that COVID-19, of course, has extensively affected a large population of patients, in particular in my country. Many of these patients had a concomitant disease, and among these concomitant disease, the metabolic risk factor and hypertension have played a major role. Hypertension can contribute to the poor prognosis of this population of patients, and the management of hypertension maybe can be very important in the initial, in patients with mild form of the disease, and probably in the follow-up phase of the disease. And in this case, probably the drug inhibiting the renin-angiotensin system could be the best solution, but we need more data for that. And I'll thank you very much.
Thank you very much, Claudio, on behalf of the International Society of Hypertension. And I should remind our viewers that we have a question and answer session at the end, which you can access electronically, of course, which will be hosted by Professor Vivek Jha from the International Society of Nephrology. So please submit your questions as and when you wish. And now let me invite Professor Donna Ryan, who is president of the World Obesity Federation and professor emerita at Pennington Biomedical in Baton Rouge, Los Angeles, USA. And Donna is going to address obesity is associated with COVID-19 morbidity and mortality. What are the biologic mechanisms? Donna.
Okay, so we know that there are a number of risk factors that have been identified for morbidity and mortality associated with COVID-19 disease, including older age, male sex, all of these chronic diseases, including obesity and immunosuppression. I'm showing you here a series of retrospective studies, mostly from Europe and the US. And these studies are emerging that show BMI as being associated with adverse outcomes of COVID-19 disease. I think I'm just going to come up here. Okay, so I already talked about these identified risk factors for adverse outcomes of COVID-19 disease. And these are the some of the early studies that have been done. These are retrospective studies in patients with COVID-19 disease. And this sample is mostly from the US and from Europe. And these studies have shown that mortality, ICU admission, and even among ICU patients, the risk for invasive mechanical ventilation is associated with a BMI of 35 or greater. And then subsequent studies have shown that even a BMI as low as 30 in these populations is associated with risk for ICU admission. So Petrilli looked at over 5,000 admissions in New York City and found that BMI greater than 40 was associated with admission and critical illness. And an interesting study by Klang, and I show you that as the last two rows on this slide, among 572 patients less than 50 years of age admitted in New York, where the mortality rate was 10.5%, the BMI of 40 or greater was as independently associated with mortality. And even for older patients, BMI greater than 40 was associated with mortality, albeit with a lower odds ratio. So in all of these studies, BMI was associated with these adverse outcomes, and overall, the higher the BMI, the greater the risk for adverse outcomes with COVID-19 disease. And these were all done with multivariate analysis, and the BMI was independently associated. So also higher BMIs were associated with greater risk, and obesity increased the risk for adverse COVID-19 outcomes in younger individuals. Now we're only beginning to see studies emerge in Asians where the cut points for obesity are different. And generally obesity, it begins with a BMI of 25 in individuals of Asian descent. And these appear to show the same relationship with COVID-19 severity. But there's a lot more that remains to be learned, even from these retrospective epidemiologic analyses. So we need better studies with more advanced body fat assessment. And these studies are being conducted and are sort of in the process of being reviewed. So I think we need to know whether the severity of COVID-19 disease is related to ectopic and visceral adiposity. And we also need to know whether COVID-19 viral clearance is related to obesity. We also, of course, need to know the best ways to remediate risk associated with obesity in patients who have COVID-19 disease. So we know that obesity is associated with many, many other diseases. For this group, we know of its association with hypertension, with cardiovascular disease, and with diabetes. And the mechanisms by which obesity produces these are either by the excess burden of body fat per se, producing mechanical stress, and that may play a role in the risk for COVID-19 severity, as we'll discuss in a minute, but also by the metabolic and physiologic products of excess body fat and where it's located. So we know that excess abnormal body fat activates the renin-angiotensin-aldosterone system and the sympathetic nervous system. And it also produces an abnormal lipid profile by virtue of visceral adiposity and its effect on the liver. But fat also produces a number of adipokines and cytokines that have pro-inflammatory, pro-thrombotic activity, and those drive risk for many of the diseases that are associated with obesity. So to sum it up, obesity can produce disease just by the burden of excess fat mass, by the prothrombotic and pro-inflammatory products of the excess abnormal body fat, and by the location of excess adiposity, be it in the visceral compartment, in the liver, in muscle, in pancreas, even in epicardial adipose tissue. So we know that a number of mechanistic hypotheses have been put forward to why obesity is producing this adverse outcome with COVID-19 infection. And one is mechanical. It's that increased body fat, especially within the abdomen, can have effects on respiratory physiology. So we know that in obesity, there's decreased expiratory volume, and we know that functional residual capacity is reduced. But there are also ventilation and perfusion defects associated with obesity. And we know obesity is associated with altered immune surveillance and response. Now, adipose tissue expresses the ACE2 receptor, and that's the receptor whereby the spikes on those SARS coronavirus 2 attach. Adipose tissue doesn't have increased expression of ACE2, but just by the volume of adipose tissue, it may serve as a reservoir for the virus itself. And then there are some interesting hypotheses that cells in the lung, the lipofibroblasts in the lung, which have a lot of similarities to adipocytes, and which we know are associated with pulmonary fibrosis, that these pulmonary lipofibroblasts may play a role in the adverse outcomes of pulmonary disease that are associated with COVID-19. But certainly endothelial dysfunction and the prothrombotic milieu associated with obesity may also play a role. So these are some of the proposed biologic mechanisms that underline the association between obesity and COVID-19. But obesity has enormous implications for global health. And here I'm showing you the prevalence of BMI of 30 or greater in adults in different regions around the world. Now, this really underestimates the impact of obesity in some parts of the world, particularly in Asia. And that's because individuals of Indian and Asian descent do not store subcutaneous body fat as people of European descent tend to. So this really underestimates the impact of excess abnormal body fat. Among many countries in Asia, the cut point for obesity begins with a BMI of 25. And to illustrate that, I'm showing you in the top panel the prevalence of obesity and overweight in the USA, and then in all of these Asian countries. So you can see that what rates of obesity and overweight are much higher than in Asia. And in the bottom panel in pink, you can see the rates of prevalence of diabetes in these countries. And the prevalence of diabetes is the same or greater despite lower rates of obesity and overweight. And so this speaks to the propensity of these populations to store body fat viscerally and ectopically in organs. So across the world, we need to be paying attention to obesity because if we're going to achieve our public health goals, we need to fight the underlying root cause of hypertension, diabetes, cardiovascular disease, and many forms of cancer. So if we're going to achieve the World Heart Federation goal of 25% reduction in premature CVD mortality, we're going to have to address the obesity epidemic. I think this COVID-19 experience underscores the fact that obesity is not a matter of body size. It's a matter of body health. Obesity is driving risk for many comorbidities, and it's driving risk for adverse outcomes of COVID-19, and we need to take it seriously. So thank you all very much for including me in this panel and allowing me to have my say about obesity. Thank you.
Thank you very much, Donna, speaking on behalf of the World Obesity Federation. And now, may I introduce Dr. Eduardo Bianco. He's a cardiologist who has advocated for tobacco control in Uruguay and Latin America over many years and contributed to the international treaty, the WHO Framework Convention on Tobacco Control. And Eduardo is going to address smoking cessation and cardiovascular diseases in COVID-19. Eduardo.
Thank you, David. Thank you for inviting the Framework Convention Alliance on Tobacco Control to be part of this important webinar. And good morning, good afternoon, good evening to everyone. On this short presentation, I will try to make the case about why tobacco smoking and smoking cessation is important and should be considered in the COVID-19 epidemic. COVID-19 produced by the novel coronavirus is an infection whose main target is the respiratory system. The entry of viruses in their replication and elimination occurs in the respiratory system. And this respiratory infection can evolve to a respiratory failure due to lung damage. Anyone could be infected by the virus, but there are some populations, and it was mentioned before, that are more vulnerable to suffer from a severe form of COVID-19 and even to die because of it. They are older people, people with chronic conditions, and those with immune deficiencies. On the group with a chronic condition, we found people with cardiovascular diseases, hypertension, diabetes, COPD, kidney and liver diseases, and of course, obesity, as it was mentioned. Tobacco, the focus of our presentation, is highly related to 4 of them: cardiovascular diseases, cancer, COPD, and diabetes, and could aggravate others. But COVID-19 also affect cardiovascular health. Among patients with COVID-19, there is a high prevalence of cardiovascular diseases, and more than 7% experienced a myocardial injury from the infection, reaching 22% of critically patients in a study. Myocardial injury is present from the onset or appears as illness severity intensifies. To better understand the relationship between COVID-19 and tobacco, let's start remembering that smoking increases mucus production, inhibits and destroys the cilia, and causes inflammation at the bronchial system, as well as affect the local immune system. That way, smoking increases susceptibility to all respiratory infection. It increases 2 to 4 times the risk of pneumococcal pneumonia and double the risk of influenza and tuberculosis. On the other hand, smoking also affects cardiovascular health. It is responsible for about 10% worldwide cardiovascular death, and there is no safe level of tobacco consumption for cardiovascular health, as just 1 to 2 cigarettes by day increases significantly the risk for acute myocardial infarction and stroke. Additionally, cardiovascular effect of secondhand smoke will be as large as those related to smoking. What do we know about COVID-19 and smoking? As we said before, smoking increases the possibility of all kinds of respiratory infection. That relationship was observed even with the Middle East respiratory syndrome, a predecessor of the novel coronavirus. Therefore, it was reasonable to expect that there could be a relationship between with the COVID-19. Additionally, smoking requires hands-to-face motion that will increase the risk of any viral transmission. WHO requested to a group of researchers to evaluate if a smoker with COVID-19 were at greater risk of developing severe disease and to die for COVID-19, and they found that relationship. A large study that included over 1,000 patients in over 500 hospitals from China showed that smokers were admitted to intensive coronary units and had more severe symptoms than non-smokers. There are some meta-analyses that studied this relationship. One performed by Bardavas concluded that smoking is associated with a poor evolution. Other by Levy did not find any difference. The last one on my knowledge from Patanavich and Glantz included more studies, concluded that smoking studies almost doubled the risk of graded severity in COVID-19 patients. We recognize that more data is needed, but given all the aforementioned, we can sustain that there is a relationship between smoking and COVID-19. If we also add that smoking impairs cardiovascular and respiratory health and produce and aggravate the predisposing condition for more severe case of COVID-19, it is reasonable to consider that the smoking cessation can contribute to the pandemic, to face the pandemic. Let's review what happened when the smokers stop smoking. In 2 weeks, lung function improves, as cilia regrow and return to normal activity levels. Bronchial inflammation decreases and immune function improves. That way, the risk of respiratory infection decreases. It also improves cardiovascular health as blood pressure and heart rate decrease. So the heart rate begins to decline 24 hours after quitting. The fact that smoking cessation improves lung function, immune response, cardiovascular health, and put former smokers, in a stronger position to fight severe infection like COVID-19. Given the burden of death and disease caused by tobacco, smoking cessation at any time represents a huge opportunity for public health. Quitting smoking is not easy, since most smokers develop tobacco dependence. But even in this pandemic, where the lockdowns can put more pressure on the smokers, they are also very concerned about their health and may be uniquely receptive to stop smoking advice. So, high quality smoking cessation advice should form part of public effort during any pandemic of respiratory viruses such as COVID-19. And so, what to do? Obviously, it depends on the country's resources and capacities. But I want to highlight some interventions that could make a difference. First, smoking cessation communication campaigns. Ideally, mass media campaigns are ordinarily cost-effective, but if you don't have money, social media campaigns are an option. Second, providing smoker support. It is not just increasing smoker awareness. We don't have to help them to quit. Offering brief advice from healthcare professionals is basic. Using online resources, different platforms, apps, the new technologies, smartphones, as a doctor had at the very early presentation raised. Facilitating access to evidence-based